Hi everyone, welcome to our CGHI forum today. Today we're talking about vaccine equity in low and middle income countries. And we invited a speaker who is a very knowledgeable person in this field. So Zacharia Kafuko, he's the director for One Day Africa, the African chapter of One Day Sooner, a global organization advocating for equitable vaccine access and ethical science-driven policy solutions. Zacharia's work bridges the gap between science, policy, and ethics, striving for a future where healthcare access is not determined by geography or income level. And today we will discuss the following topics: understanding the vaccine equity landscape and what is working and what isn't, and the future pandemic preparedness and systemic barriers and challenges and next steps for global vaccine distribution. And we will be collecting questions in the chat box. And also we'll have a general discussion section in the end, and also a Q&A. And I think our speaker would also want to make this webinar more interactive. So maybe he will invite people to ask questions during his presentation. And quickly about CGHI for people who will be watching us when we publish this recording on our YouTube channel. So the Coalition for Global Health Innovation is a youth-led nonprofit. We have more than 100 community members from 6 different continents. And what we do is to empower young professionals and emerging leaders in global health and development. We organize important webinars and forums, online events like this one, talking about the important topics in global health, advocating for marginalized groups, and equity and inclusion. And we also write articles and blogs, and we publish on our website. And we also meet every 2 weeks in our community call where we network, share resources, and we provide peer mentorship. And we also provide, our very diverse networks of senior professionals as well. And in the future, we'll also have a series where we will invite our senior advisors and just senior professionals in our networks to answer our questions for us to have a chance to engage with them. So thank you everyone for joining us today. And I'd like to invite Zacharia to start his presentation. Thank you.
Yeah, thanks, Charlie, and nice to meet you, everyone. I hope you can hear me loud and clear. Okay, yes. So I think just to get started, if you let me, I'm going to share my my screen. Yep, I think that's the one. Okay, so Elena, can you see?
Yes, perfect.
Perfect. All right. Okay. So getting started, as I think I've already been introduced, I will not go much into my own introduction. So maybe as a way of starting, I know I actually touched on this a little bit, so I'm just going to maybe add a bit of further context. So One Day Africa, as mentioned, is the African chapter of One Day Sooner. One Day Sooner is an international medical nonprofit organization that leads campaigns in science, policy, and ethics to fight or stop the world's most harmful infectious diseases. So we have a very strong research that informs these decisions and these policy recommendations, as well as advocacy. So it is important to note that while One Day Sooner does lead global campaigns at the intersection of science, policy, and ethics, working to combat the diseases we mentioned, One Day Africa does focus a bit more on issues around vaccine equity and future pandemic preparedness, specifically for low and middle income countries. So just to maybe give a bit of a background as to this topic on vaccine equity for low and middle income countries. So maybe some of us on the call remember this image or similar images really. This image is trying to give us a background why this conversation is very necessary at this time, at this age. So this picture is a source from WHO and CDC. Specifically, this was compiled by Worldometer, which, as some of you may know, was compiling data for COVID-19 during the pandemic. So this was the distribution of COVID cases globally. Now, as you can see, the distribution is wide. All continents were touched, all continents were affected. And I think while we're on this slide, it's also important to note that some of the clear countries that you can see on the map are not necessarily as a result of not having COVID cases, but usually was because they were not sharing their data. Now, usually when I make presentations, I also like to give a bit of context to the name One Day Sooner, because sometimes it does sound a bit, I'm gonna say unique or just different from most names that you'd expect for a nonprofit. So this is actually as well taken from Worldometer. These were statistics around the peak of the pandemic. So you can see how the daily death toll was looking in January of 2021. You can see 16,000 people dying every single day. Now, when you think about what 16,000 people looks like, I think you can conceptualize how serious this pandemic was. And we have the high number around 17,000, which was, I think, on 21st of January 2021. Now, the name One Day Sooner was actually adapted from the pandemic. Our understanding and our argument then and even now was still that if we can get medical countermeasures like vaccines to the people who need them, even just by a day sooner, we potentially would be saving thousands of lives. And if we are to take the case for the peak of the pandemic, if we manage to get these vaccines to the populations that need them, arguably we'll be saving tens of thousands of lives, perhaps 17,000 lives, even just by having those medical countermeasures like vaccines arrive even just a day sooner. So I just wanted to maybe broaden that context. Usually when people think about low and middle income countries, I think most people quickly think about Africa. Of course, Africa is not the only region which has LMIC countries. We also have in Southeast Asia, we also have in South America. So I just picked the African continent just to give, I think, context, because I think most people resonate with Africa being a continent predominantly filled with low and middle income countries. So this continues to be the depiction of the COVID-19 situation on the continent around 2020, 2021. So there was a huge case presence and also mortality, not just in Africa, obviously, but globally. And when the world was now evolving or emerging from the dire situation towards the solution or towards the world handling or responding to the pandemic, I think we had the first cases of COVID vaccines towards the end of 2020. And what was the situation then? If you look at the total cases for COVID-19 to date, we had about 700 million cases globally. 700 million cases. That's a very, very big number. And you can see why this was a global problem and why I think in many respects it requires and required a global strategy or attention. We had more than 7 million deaths that were recorded. But then it's also important, as I'm broadening this background to why we need vaccine equity, it is also important to note that when the vaccines became available in late 2020, the sad reality was that about 88.8% of the vaccines that were available at the peak of the pandemic went to high income countries. And I'm talking about 88 That's a huge proportion of the available vaccines. Now, I'm putting this 20% just to show you what percentage of global population actually is in the high income countries. So it's just about 20%. So we are saying 20% of the global population took 88% of the available vaccines during the pandemic. So effectively, what was left for the 80% of the rest of the world was just about 11.2% of the available doses at the time. 11.2% of the doses that were supposed to be shared with the 80% of the global population. You can even go further into that and realize that, for example, Southeast Asia only accounted for 3.9% of the vaccines that were available. So only 3.9% of the vaccines that were available then went to countries in Southeast Asia. You might be wondering how many doses or what percentage of doses went to Africa. 0.7%. Now you need to think about that just a little bit. When you think about 0.7% of the global chunk of the vaccines actually went to the entire continent of Africa, which, as you know, more than 1.4 billion people, accounting for roughly just over 20% of the global population. So from these slides, you can see the huge disparity and the huge inequality in terms of vaccine access and the total absence of vaccine equity. And these were some of the triggering situations or developments that led to even wider cries and concerns around how health access should be considered and viewed, especially in the view of pandemics. And we can confidently now obviously say that we are no longer in the COVID-19 pandemic, but we still have issues with other infectious diseases and obviously even non-communicable diseases. So this is just to give you an indication of some of the leading causes of death in Africa. Sorry, I keep picking on Africa because it seems like the classical example when you talk about LMIC countries or regions. So you can see the leading causes of death for Africa, which in this case is representing LMIC countries generally. So we still have a lot of diseases that still continue to claim thousands and millions of lives in Africa. To give an example for malaria, for example, malaria kills about 1,000 children every day. 1,000 children die of malaria in sub-Saharan Africa every passing day. So when you try and interpret these kinds of statistics into what should be happening and how these things should be done, it quickly begins to push you towards needing a bit more fairness, justice, and equality, and hence brings us to why we need vaccine equity, and by extension, why we need pandemic preparedness. Have we learned our lessons from the past? Have we learned our lessons from the COVID-19 pandemic? I don't know if there's anyone on the call who can say we have learned our lessons and who can confidently say that the world is doing significantly different and is expecting to be a different ballgame in the next pandemic, whenever that will be. And obviously, probably we haven't learned, and maybe we shall find out. But really, the lessons that we experience or the situation we experience, especially with the COVID-19 pandemic, demonstrates significantly why vaccine equity and conversations around vaccine equity and global health are very necessary. So apart from that, we also need vaccine equity because, vaccine equity underpins global public health. Now, I think a lot of you here are very familiar with, global public health, concepts and principles. And we do, fully understand what it means when we have a world where diseases can easily spread. And this is what actually leads us to the point of globalization and infectious diseases. One thing that became very clear during the COVID-19 pandemic was that infectious pathogens really do not respect borders. They don't need visas, they don't need passports. And we can confidently see how that situation unfolded during the COVID-19 pandemic. So the pathogen, for example, the SARS-CoV-2 virus, which was initially or first identified or discovered in Asia or in China, how then did it come to affect the entire world? One of the reasons, obviously, is that nowadays ease of transportation and movement has really improved. So a person can be on one part of the globe today, and by the end of the day, they can be in a different part of the world. And because of this, it means that even the transmission of infectious agents has become significantly easier as a result of the ease of transportation or what air travel has made possible. Now, because of also this ability to move quite quickly from one point to another, it means that most infectious diseases can be transported or transmitted below their incubation period. So diseases like Ebola that require maybe 2 weeks for them to become symptomatic. Imagine a person who contracts it today and tomorrow they are traveling to the United States of America from Africa. And by that time, they will not be symptomatic. So it means that the potential for continuous distribution of these infectious agents remains very high. And the only way to be responding or to be thinking about responding towards those kinds of potentials is through vaccine equity and obviously pandemic preparedness. Those of you who are also familiar with SDGs, I think you agree that SDG 3 focuses on universal health coverage. Now, universal health coverage is also attached to what is now has become the One Health approach. Now, the One Health approach does allude to the fact that because of the recent developments that the world has seen, it has, become much easier for the interaction of humans with animals as well as with the environment. As humanity is breaking new grounds in terms of building new infrastructure, occupying newer territories as the global climate is changing, we are now coming more into contact with organisms that otherwise would not have been in contact with. As the ice caps are melting, organisms that were, for example, restricted or focused in one part of the world now can easily move. And because these places are becoming more accessible to humans, human beings are also moving into these environments. And all these are creating new potential for transmission. And what that simply means is that as we continue to engage closer with animals as well as the environment, the potential for zoonotic transfer and otherwise with pathogens is becoming higher. Then vaccine equity also has an ethical imperative. Now, in the introduction, Charlie mentioned that one of the things that we do at One Day Sooner is to push for countermeasures in a timely manner that resonate with ethics of humanity. So there is an ethical imperative that we need vaccine equity. Now, sometimes one way to think about this is that, like the way we are on this call, there is no one on this call who can claim that they chose which country they are going to be born in. No one on this call can claim that they chose which two human beings were going to be their parents, right? So all of us are basically born into wherever we are born as a matter of pure chance. Now, if health access or the preservation of life is going to be determined by where you are, especially when you did not choose, there remains an ethical imperative that everyone around the world, regardless of their geography, requires an equal opportunity towards health access, toward health services, and therefore vaccine equity reinforces this need to protect all life regardless of the location. And principles of global justice also highlight this particular point. Some of the things that we saw happening during the COVID-19 pandemic, for those of you who recall, you remember that there are countries, I'm not going to mention names, but there are countries in the world which had stockpiles of vaccines. Meanwhile, as you already saw from the earlier slides, regions like Africa had only received 0.7% of the available doses. While this was happening, countries had stockpiles. Some countries even had enough vaccines to inoculate their populations up to 5 or 10 times over. Now, imagine a country which is holding vaccines that can, vaccinate their populations more than 5 times. What is the essence there? Is there global justice when others, have literally nothing, as it were? So there also remains the principles of global justice when it comes to allowing a fair and equitable access to these life-saving interventions. The last point on why vaccine equity is important is the fact that, like all living organisms, mutations, occur in pathogens. Whether it's viruses, whether it is bacteria, mutations do occur. Now, the scientific principle here being that the longer that a pathogen is allowed to circulate and transmit from individual to individual, the higher the mutation potential becomes, the higher the chance that this organism is going to adapt in a different way or is going to change its behavior and ultimately its ability to medical countermeasures or how it responds to interventions. And some of you also are already aware of drug resistance as a result of these mutations that occur. Now, we can confidently pull in lessons from the COVID pandemic because we had so many variants that were coming up. I'm going to refer maybe to the Omicron variant, which was first detected in the LMIC region. And the Omicron variant was detected. The borders were closed. The countries where this variant was spreading, they were put on travel ban list by other countries, as it were. So we can see that there are a lot of pieces that are playing as a result of this. And I'll maybe quickly go into the concept of vaccine equity. Now, vaccine equity allows and requires the speedy translation of new or existing research into medical countermeasures. Now, what this means is that when there is new research or when there is existing research, at the point when an outbreak occurs, this research should be quickly translated into medical countermeasures, whether it be diagnostic tools, whether it should be therapeutics, whether it should be vaccines or treatments, whichever one it is. These ones should be quickly translated into medical countermeasures. Now, apart from the speedy translation of these research pools, these medical countermeasures need to be decentralized. Now, how this decentralization occurs, one would be through decentralization of vaccine manufacturing. One of the things that was unfortunate during the COVID pandemic was that the majority of the vaccine manufacturing capacity was actually in the high income region. And you remember, because of this, there was preferential access for those countries and citizens of those countries, leaving the rest of the world without access to these important life-saving vaccines. And some countries even went further by imposing export bans. So even if they had manufacturing capacity, they no longer accepted to be shipping these vaccines to other countries or other regions. So this also now begins to the picture of why these kinds of conversations are very necessary and why we need to do better next time around. And then to ensure that there's vaccine equity, there is also a need for reserve funding for vaccine purchase. Now, the reason why this is even an issue right now is because different countries have got different, income and different, financial standing. There are countries that are very wealthy. There are countries that are extremely poor, where citizens even don't have access to clean drinking water. So to expect that these countries, in the case of a pandemic, will have readily available funds to buy or purchase vaccines is simply asking for too much, and to an extent, being very, very unfair or insensitive. So as one of the modalities to ensure that there is vaccine equity, there is a need, and there has been proposals to have a reserve funding that should be specifically for global vaccine purchase. And the next point is around establishing and incentivizing a global policy process. Now, this global policy process would do two things. Number one, it would be waiving the intellectual property protection. Now, as we know, when, let's say, a pharma company like Moderna or Pfizer, as it happened during the pandemic, develops a vaccine, they own the intellectual property rights for that particular product. Now, in the event of a pandemic, especially where manufacturing capacities are limited, how do we ensure that vaccines are able to reach everywhere very quickly without necessarily depending only on the production line of that one facility which owns the IP for that vaccine? One way of doing that is by waiving the intellectual property protection so that the vaccines become a global good. And by doing this, it would allow for generic manufacturing. So for all the countries or regions which have facilities that can be modified or updated to produce this particular vaccine, they can begin to produce or manufacture generic versions of this vaccine. Now, this will allow for quick access. It will allow for decentralized access, and most importantly, it will allow for these other LMIC regions to continue to also benefit from the availability of the vaccines without necessarily having to, without necessarily having to make trade-offs from the high-income countries whose populations, to be fair, also need the vaccines. So waiving IP allows for generic manufacturing, which allows for easy access and decentralized access. The next point is on fair pricing for the life-saving countermeasures. Now, the issue of fair pricing should in reality not even exist. But unfortunately, we have learned from the pandemic times that there are manufacturers or pharma companies that were having different pricing for the vaccines. To give an example, the price per vaccine which the European Union was paying for AstraZeneca vaccine, which was produced by Oxford, was different than the price which the African Union was given for it to purchase vaccines for the continent. So it was discovered that the pricing that was given for the African Union was almost 3 times more than the price which the European Union was paying. Now, you can think about the optics or what this actually looks like, but I think it's fair to say that to be forcing the low and middle income countries to be paying even more than the high income countries, regardless of the reasons, is obviously very unfair and unfair business practice, to say the least. So this is why now these conversations around ensuring fair pricing are being held now and should be held, so that if it comes to the point where countries are trying to buy, they should buy at fair pricing or equal pricing at the very least, instead of having different pricing for this region and for that region. And the last point on ensuring vaccine equity is obviously on local vaccine manufacturing, which I think I touched on a little bit on the waiving of the IP protection. Maybe I'll pause here in case there's a question, and also for me to catch my breath. Okay.
Thank you, Zacharias. Yes, let's see. Sorry, I said Zacharia because I see our Dr. Zacharias is here. Are you able to speak? Because he will leave us very soon. He's a very senior professional in global health. I believe he's in his 80s and he's been a mentor to me and to many young people. So I wonder if not, then I will invite Julia to ask a question. Julia, go ahead.
Yeah, so thank you so much. This is this is giving me a lot of insights and it's very interesting. I was wondering how does it even happen that they raise the price to 3 times? Like, how does something like that even occur in the first place?
Yeah, that's a very good question. So the first answer I'll give personally is that it's ridiculous. The answer I'll give professionally is that part of the reasoning or the logic that went into that pricing tiering system was because the countries in the European Union had invested or were the owners of the manufacturing lines that were producing these vaccines. So if, for example, the manufacturing plant is located in, for argument's sake, is located in Belgium, and this company maybe pays taxes or has tax, waivers or incentives like that, it becomes almost reasonable or expected that it's going to be providing favorable pricing for the country where they are operating. So largely it was because the European Union had pumped some money into production as well as long-term ongoing research, as is the custom right now. I can tell you for a fact that, just as an example, maybe until recently, that the US government does fund a lot of medical research and clinical studies through the NIH. And obviously other institutions, including to Johns Hopkins, for example. Now, what does this mean when the US government is using taxpayers' money to fund medical and clinical studies in these institutions? And these institutions, when they have a breakthrough, you should expect that there's going to be some kind of, for the lack of a better term, I'm going to say some incentivized pricing for these countries and for these governments, because they, are sort of, in a manner of speaking, shareholders in the studies or in the research that has been going on. So that was the main reason or the main logic that went into that pricing tiering.
Thank you so much. Wow, thank you.
Cool. Do we have another question? I can proceed. Okay, I think I can move ahead. So talking about pandemic preparedness, what exactly does it mean when we talk about pandemic prevention, preparedness, and response? So ideally here we are trying to talk about ensuring that there are systems, there are processes, and there are policies in place to make sure that when a pandemic does happen, it should be responded to with the maximum possible efficiency and record time, obviously. So a lot of the conversations around pandemic preparedness are more future thinking recommendations, future thinking conversations, future thinking policy recommendations and suggestions, as it were. Now, if you look at the specific nitty-gritties of what so far has gone into pandemic preparedness, and also, to be fair, this has largely been informed by what we experienced during the COVID pandemic. So number one is on enhancing disease surveillance and detection. Now, what this does, or what this presents as an opportunity, is that in the event of, let's say, a zoonotic transfer or just a detection of a pathogen that begins to spread, if there is enhanced disease surveillance and detection, it means that this pathogen will be quickly identified and studies or research can begin immediately this happens. Now, whether or not there is going to be already existing research or it's going to be a novel pathogen that will require fresh studies, that is a different topic, I guess, for conversation. But the point being that with enhanced disease surveillance and detection, this allows for quickly being able to detect and identify an emerging pathogen within a population. And as you know, once the pathogen has been identified, some of the very early pockets of research that go into that is to try to understand, first of all, its character, its behavior, how it is transmitted, its virulence, and all these factors that also lead now into its susceptibilities or vulnerabilities that now translate into how this pathogen can be, number one, handled, or what protections people can apply to prevent infection or transmission, and most importantly, how this pathogen can be neutralized, whether through therapeutics, treatments, or through preventive approaches like vaccinations, as it were. So that is number one on being pandemic ready or being prepared for the pandemic, enhancing disease surveillance and detection. And I think we'll be talking about this a bit more when we come to current efforts in pandemic preparedness. Number two, under pandemic preparedness, is on strengthening laboratory systems. Now, this has also in recent times included genomic sequencing capabilities. As you know, because especially of the fact that there is the re-emerging of pathogens we have dealt with in the past, it has become necessary that we should have capacity for genomic sequencing, because this will allow for us to know specifically what kind of a class or subclass of a pathogen or microorganism we are dealing with, especially if it's not a novel pathogen. And even if it's a novel pathogen, it still remains important to try to understand at its molecular or DNA level what kind of pathogen we're dealing with, what its sequence looks like, and thereby trying to better understand how it can be neutralized or how it can be handled. So a lot of the laboratory system strengthening that is going on is trying to ensure that there is inclusion of this particular aspect of genomic sequencing. And in the event or in the case where we're dealing with a pathogen that has existed before, obviously, as people on the call already know, the COVID-19 pandemic was as a result of a SARS-CoV-2 virus. Now, the family of SARS viruses is not exactly new. We have experienced them before. In the past, we have had some existing studies and research that had been going on at the emergence of SARS-CoV-2. Now, what this allowed, or what this presented perhaps as an opportunity that maybe changed how the pandemic actually eventually played out, was the fact that there was very little time that was needed to actually fully understand what pathogen we're dealing with and how to handle it, because we did already have existing studies and research that went into the family of SARS viruses. So, which is also the reason why sometimes people have raised the argument in terms of how come the COVID vaccine was developed very quickly. It's because there was already existing studies that had gone into the family of SARS viruses. So this is one way of ensuring that we are preparing for the pandemic, so that whichever region of the world where a pathogen emerges, it would be very quickly to, number one, detect, and number two, to identify or sequence it to perhaps even up the molecular level, depending on what pathogen we're dealing with. And this allows or opens up the potential for a lot of, solutions or interventions that can be developed. And especially now when we have mRNA capable, facilities around the world that can, quickly modify structures to, to try and test out which of the options would work best for this particular pathogen. The other point on being pandemic ready or on pandemic preparedness is on increasing the number of healthcare workers, and secondly, improving the conditions of service. Now, here, as you notice, this conversation is on the low and middle income countries. This particular point is perhaps not a very big priority in high income countries, but for low and middle income countries, the issue of increasing healthcare workers and especially the issue of improving their conditions of service remains, a discussion point year in and year out. This is actually what has led to the issue of brain drain. So the most capable, most qualified, most gifted healthcare workers and researchers end up migrating to high income countries because that's where, there's better conditions of work, there is better pay and all these kinds of, perks that come with being in a high income country. So until these issues are being addressed, the potential for brain drain remains very high. And as more skilled people are leaving the LMIC region, there is a gap that is being created in terms of how these LMIC regions can respond in the event of a pandemic. So this remains also an issue that needs to be addressed if we are going to be considering pandemic preparedness. And then there is also the issue of ensuring regular capacity building at critical levels. Now, the ideal statement here should be that regular capacity building at all levels. But as you know, in the LMIC region, the funding challenge is real. So there's always going to be trade-offs that need to be made. Now, in the event that these trade-offs are being made because of the limited availability of resources, then what are the critical levels where this capacity building has to be done? So obviously on disease surveillance, on laboratory systems, and other forms of medical and clinical research. These are very critical in responding to pandemic preparedness. So ensuring that there is regular capacity building ensures that there is the highest possible level of capacity or skills amongst the available workforce that could contribute towards responding to a pandemic when it happens. The next point is creating mechanisms for quick availability of funding for response. Now, this particular response could be at management level and could also be at intervention level. Now, what this actually would look like, or what this looks like, is that in the event of an emergency, one of the things that has been discussed extensively is that there must be a pool of funding that becomes unlocked in the event of a pandemic. Because most governments, especially in the low and middle income countries, do not have sums of money just sitting and waiting in case something happens. Every dollar that is available in these countries ends up being used. There are so many competing interests, from clean water provision, from education and energy and all these kinds of things. So the availability of funds that could be used in the case of an emergency or a pandemic or an epidemic or an outbreak usually is very limited. And this is the reason why there is a need to deliberately create mechanisms that would unlock funding that would quickly be available for pandemic response to manage, which means, for example, under management, it could include recruiting community health workers or recruiting volunteers, or building, let's say, temporary shelter for people who are getting sick, where the hospital capacities are limited, as you saw this happen during the COVID-19 pandemic. The intervention part now looks at things like research, studies, and potentially vaccine development or R&D in general. The last point under pandemic preparedness is on creating vaccine production and access platforms. So this point was also touched on the vaccine equity side when we're talking about local vaccine manufacturing capacity. So this works very well under pandemic preparedness, because what it means is that when a pandemic does occur, there is going to be facilities or platforms that can produce either their own IP or patented vaccines, or that could potentially be able to produce generic versions of the vaccine or whatever therapeutic or treatment that may be available. And these platforms will also increase decentralized access. So if, for example, we have facilities in the LMIC region, it means when these facilities are producing, the local populations or the region within which they are located can have access to vaccines. So this goes into pandemic preparedness. I'll try to be quick on this one. What are the current efforts or programs that are running on vaccine equity? The first one is the mRNA Tech Transfer Program. Now, this program was initially piloted by the Medicines Patents Pool. And then later on, the World Health Organization also became a partner and started funding. So what this mRNA Tech Transfer Program is doing is that it is creating mRNA-capable facilities in 15 countries in the low and middle income region. So Africa has 5 facilities, Southeast Asia has 5, and South America also has 5. This was the first site for this program was actually started at Afrigen Biologics and Vaccines in Cape Town in South Africa. So it is a program, for example, that we have been a part of from the time it was started, and continues to create these mRNA-capable platforms in these 15 LMIC countries, with obviously the goal of increasing vaccine access, decentralizing access, and obviously ensuring that there's going to be equity as we look into the next pandemic. And then the mini labs. So this particular program was actually engineered or inspired by Pfizer, which was distributing what they called mini labs to select African countries. At the time when this program was launched, the plan was to put these mini labs, mini vaccine manufacturing labs in Senegal, as well as in Rwanda. We know that Rwanda has proceeded. We don't know what happened for Senegal, but these are some of the incentives that were being designed to ensure there's localized access to vaccines. And the argument then was also that even pharma companies like Pfizer could use these mini labs to produce for the local populations when a pandemic happens. And then there is the pandemic accord. So the pandemic accord is what was proposed during the World Health Assembly. I think this was 2021, following the COVID-19 pandemic. Now, what this was aiming to do was to create an agreement among all countries on how the next pandemic should be addressed and what needs to be put in place. Now, because of the complexity of coming up with such a tool, there was a lot of diverging views, a lot of opinions that were available, and they could not arrive at easy consensus. So as a result of that, the WHO recommended the creation of the INB process, the Intergovernmental Negotiating Body, specifically charged with the responsibility of negotiating specific terms with countries. These are the terms or clauses that would make what now would become the pandemic accord or the pandemic treaty. So these discussions have been going on. We have been part of them. And as we sit now, I think we are on INB number 10, going to 11. So it has continued to undergo revisions and updates and things like that. So ideally, some of the things that come within the pandemic accord circle on matters, for example, on how the pandemic should be funded. Vaccine purchase, how should it be funded? What does the world say, or where does the WHO stand on issues to do with vaccine access and equity? So those are the negotiations that are going in through the INB process. The pandemic fund, as it is now being referred to, was started by the World Bank as the Financial Intermediary Fund. What this particular fund was proposed to do in trying to address vaccine equity is captured in what I mentioned under pandemic preparedness. So the key principles of the pandemic fund, or the financial intermediary fund proposed by the World Bank, and which has actually started to be funded, was number one, increasing disease surveillance around the world, especially in the LMIC regions where there were gaps. Number two, it is on enhancing or strengthening laboratory systems. Then number three, it is on increasing the number of healthcare workers in the LMIC region. So this pandemic fund was designed to have about $10 billion every year. And this money would go specifically towards supporting these programs in LMIC regions, setting up laboratory systems, setting up disease and surveillance capacity, and also using some of that money for increasing the number of healthcare workers. So even as we speak, the second round of funding is expected to go out because the first round already did fund projects that countries applied to have. So this is a current effort that is going on. The other one is the activation of the Africa Vaccines Regulatory Forum, which is an arm of the WHO Afro region. So what this one does is to create a forum or a platform where national regulatory bodies or authorities in the LMIC regions, for example, could meet under what is known as CIPA, the Collaborative Procedure for the Accelerated Registration of Finished Pharmaceutical Products, so that when there's a pandemic, for example, each country should not take its sweet time to do the review and regulations and approval for a new vaccine, which sometimes can take anything from 3 months, sometimes up to 9 months. So such kind of a platform like CIPA or AVAREF would allow for all countries to come together, review the data for whatever vaccine is available, agree, and then basically provide in principle approval for this vaccine in the countries, so that each country only has to take about a few weeks, and then there is a legal provision that allows for these vaccines to be introduced in the countries. And by doing this, this would save anything from 2 months to up to 8 months of operational time, and thereby increasing the speed at which these vaccines get to the populations. And then CHIM utilization. So the CHIM model, which is the controlled human infection model, is a type of clinical study where fewer volunteers, for example, are needed, and also where these clinical trials or studies are taking place under controlled environment. So it is defined as a deliberate exposure of healthy volunteers to either a vaccine or a therapy to understand how this particular product behaves or how they respond to it. Sometimes it can be a characterization study and so on. But this approach is known to be much quicker than the conventional phase 3 trials or studies that could take even up to 2 years for clinical trials to conclude. Because, as you know, a vaccine, before it can be rolled out to a population, needs to be tested, needs to undergo clinical trials and studies to ascertain, immunogenicity, the safety profile, and efficacy. So these studies would provide a quicker route for these clinical studies and provide at least the early, pieces of data, which can either be used to down select from whatever available options, or at least to expedite those promising candidates into larger scale studies. And there's been launch of vaccine manufacturing fora. The example I've given is just for Africa, but there are also wider fora that are being created. I know there's one also in South America, and I think one in Southeast Asia. So these ones are trying to put together efforts and resources and technical expertise that would be used by the region towards vaccine manufacturing. It's quite similar to the mRNA tech transfer program. And in Africa, there's also been now the activation of the Africa CDC Discovery and Development Research, which is a brand new department within the Africa CDC aimed at enhancing clinical studies. And the last point is on collective and collaborative advocacy for policy. So this, I think, rests with organizations like CGHI to try and advocate for policies that are progressive. These are some of the bottlenecks that I've listed. I don't think I have to go into these specific depths or details, but just to highlight that these are the current bottlenecks and challenges around vaccine equity and even around future pandemic preparedness. To pick out a few maybe worthy ones is vaccine hesitancy and product quality concerns. So one of the things that has come out of these discussions is that there is an understanding that perhaps the type of quality of vaccines or products that would come from the low and middle income countries would be questionable. It would not meet the standard, for example, of vaccines produced in Europe or vaccines produced in America, as it were. So these are some of the challenges that still need, to be worked on. And I'm happy to answer any questions on these if anyone has questions. This is supposed to be the last slide for today. But what are the critical ways of navigating the new global health landscape? And we are calling it the new global health landscape because there's a lot that has happened in terms of global health in the world. Some of the traditional big funders for global health initiatives have recently pulled out from supporting and funding these very important initiatives. So what remains to be done in the gap that has been created as a result of the withdrawal of these huge supporters for global health, or traditionally historical huge supporters of global health? So one is on diversification of resource mobilization. So looking elsewhere, for example, local businesses like mines in these low and middle income countries, because there are a lot of mines, as you know, in the LMIC world that are operating, and as part of maybe their corporate social responsibilities, these could be used as new sources of mobilizing resources for pandemic preparedness as well as vaccine equity. And then championing of regional philanthropy. So there are a lot of wealthy people all over the world, including the LMIC regions. So trying to expand the championing of the concept of philanthropy, even in the poor regions, so that the few that have lots of resources can also commit some of those resources towards vaccine equity and pandemic preparedness. And obviously rebudgeting and reprioritization. So as I mentioned earlier, the low and middle income countries usually are not going to have money just laying around and waiting to be used. Every dollar is already accounted for and is ready to be spent, to the point that sometimes, more often than not, countries actually have to continue to get loans, and some of these countries are just going deeper and deeper into debt. So one way of trying to navigate the new global health landscape where funding from traditional supporters is no longer existing is to look at rebudgeting and reset the priorities in terms of what is needed most. And there's obviously the increase of South-to-South collaboration. So increasing collaborations within the low and middle income regions. This would create a better, medical and economic ecosystem that would allow for sustainability to happen for these kind of initiatives. And I also mentioned here that CGHI is an example of new innovative strategies for addressing the emerging shifts in terms of traditional support for public and global health. So there is need, to have more initiatives and innovations around addressing some of these challenges. And most importantly, the idea is to remain, especially from an organization like CGHI and other civil society organizations, other nonprofits, the idea is to remain very proactive and reactively energized so that there is vibrant global advocacy that is continuously going on. Because when the world is silent, especially when advocacy groups are silent, it paints the picture that everything is rosy. It looks like there are no problems around the world. So the more advocacy is done, the more attention continues to be given to the issue, and even potential solutions are likely to be provided as a result. And this is where I end my presentation. Thank you.
Thank you so much, Zach, for your very, very informative presentation. And there are some questions in the chat box. But first, I will I will read out what Dr. Zacharias sent in the groups earlier. Zach, thank you. So Dr. Zacharias, he used to work for WHO and PAHO, and he was working there for, I think, over 30 years. So I'll read out his comments. Vaccine and medicines equity is essential. In the Americas, we have a rotating fund at PAHO for collective bargaining on prices and making vaccines. 21 at present, to all the countries at an affordable price. And then also with HIV, we started the same process to purchase ARVs in 2004. In addition to this, some countries, Brazil, Mexico, and Argentina, started producing ARVs. The message is that this can be done, but it takes many years to accomplish, and you need to have the infrastructure for storage, transportation, distribution, and application at the community level. And then before he left, he said, congratulations to Zacharia for an excellent review of the subject and the explanation about how to ameliorate the problem. Thank you. And then Said and Julia also have questions. But before that, I also want to mention that in my own research, I read that the African Union has this agency called the African Medicines Agency, and they were established to strengthen the regulation of medicines, vaccines, and medical products across Africa. It also aims to improve access to safe, effective, and high-quality medical products while reducing reliance on external regulatory systems. So I want to ask Zach if you have any comments on this agency, because I think our community might not know very much about this agency, and also like the efforts that come from Africa and from the intergovernmental organizations within Africa, because we always look at the West. So I would love to hear your comments. Thank you.
Yeah, thank you actually for that. So it is true that the African Medicines Agency does exist, and albeit it's a new agency, as you probably already discovered. So I think the concept is that the pandemic, for the most part, laid bare a lot of the gaps and challenges around how we as LMIC region should prepare as well as respond to emerging threats from pathogens. So the creation of AMA was one of the steps in responding towards the gaps that have been observed on the African continent. So apart from Africa, for example, not having manufacturing capacity for vaccines, talking about end-to-end production, not just fill and finish, which we know we have in, I think, a few countries on the continent. but end-to-end vaccine production. So that aside, there was need to ensure that there is proper regulation. Now, what this was responding to in part is to try and reinforce confidence in the medical products that come from the LMIC regions or from Africa in this case. As I mentioned in my presentation, there is a lot of vaccine hesitancy in Africa and obviously in other parts of the world. And part of that hesitancy is as a result of the mistrust of the processes that are involved in the production of these medical products. To say the least, even the vaccines that were being sent to Africa during the COVID-19 pandemic, some of those experienced a lot of, a backlash, I can maybe talk about the specific comments that were being made about certain vaccines and things like that. But ideally, the point I'm trying to make is that people have doubts around medical products and vaccines. Worse for those that are produced somewhere else, right? But also for those that are produced locally, they have concerns on quality and safety. And this is part of the reason why the African Medicines Agency was set up to sort of create a layer of confidence in the product. So it's like, okay, yes, these are the products, and these products have been inspected, they have been assessed, they have been certified by Africans who are going to be part of the people who take these vaccines. So that is where I think I would say that that has largely come from. Secondly, I think this also has been sort of a preparation towards what Africa has been positioning itself to, begin to produce more vaccines or, to produce vaccines in general. So one of the gaps obviously is on regulation. So that was being thought of as one of the processes or steps that is necessary towards vaccine production. In my opinion, this should have happened, simultaneously, having infrastructure being developed for these vaccines and then having the regulatory agency also set up. Because now we have the agency which is existing and now is waiting for infrastructure for vaccine manufacturing, which is a bit odd, in my opinion. But yeah, that's the comment.
Thank you so much, Zach, for the comment. And we have 3 questions in the chat. I will read them out. So Said asked, do you think there are any public-private partnerships that can not only strengthen vaccine production, but also its availability in low, middle-income countries?
Yeah, I thank Said for that question. The answer is yes. These PPPs do exist. There are not many, but they do exist. I don't know if I should mention this here, but I am and we are aware of some of these partnerships, for example, that have actually contributed to getting malaria vaccines in some countries in Africa. Because as you know, malaria vaccines fall within WHO's, important vaccines or, important diseases, as it were. And it's the reason why UNICEF and Gavi have been paying for these vaccines. But it's also important here to note that the UNICEF and Gavi process is very, very slow. So from a time that a country submits its application to roll out malaria vaccines, it's quite easy. It can even take a year before the vaccines actually arrive in the country. So these public-private partnerships have now started coming up where some countries are preferring to go directly to the manufacturer to try and negotiate a price. The only caveat here obviously is that the price which, for example, vaccine manufacturers give to Gavi and UNICEF is going to be quite low because of the bargaining power, the bulk buying, and also the lower risk of repayment defaulting, right? which is not usually the case when individual countries go to this. But otherwise, yes, these partnerships do exist, and I'm aware of a number of them for very particular vaccines and pathogens. And the other point also is on the actual manufacturing. So there's also partnerships that are going on actual manufacturing. The example I gave of the mini labs is another example of a public-private partnership where Pfizer provided the labs for vaccine manufacturing to a country to allow or to enhance its laboratory systems and also update its manufacturing capacity.
Thank you, Zach. And Nsovo from South Africa asked a question. During COVID-19, how were the changing variants determined? For example, Omicron was announced in the first world country, and all of a sudden South Africa would have the same variant.
Yeah. So I think the best way to respond to that is variants are usually detected through surveillance. Now, this particular surveillance is usually at a point of care, especially during a pandemic. So when people become sick or whatever, they go to the hospital. As part of the treatment process, they have to be tested, and part of that testing involves PCR. And for some well-financed facilities, that also involves sequencing. Now, the sequencing both responds to confirming that the cause for this infection is actually what we are suspecting. And number two, it is set out to understand if it's a different form of pathogen than what is circulating. And usually this is how new variants are detected. So I know the example of Omicron has been mentioned, and I think we know the sort of geopolitical drama that unfolded from the Omicron variant. I think I did touch on this, where borders were being shut and all these kinds of things, and there is even the argument that has been raised that such kind of response, like geopolitical response to data which is shared, disincentivizes countries from sharing research data, right? If we detect that we have a new variant or a mutation has occurred in the circulating pathogen in the population, we know that if we share that there's a new pathogen, there is a likelihood that all citizens in the country or in the region are going to be, barred from traveling to other countries. And, in a world where countries are also trying to break even with their economies and their GDPs and all these kinds of things, these become, unfortunate considerations when a country is afraid of losing its investments because it may lose business travel or, projects if they share this kind of information. And I don't want to go too far into this particular, topic, but otherwise, the Omicron was a very, very unfortunate mishandling of, the science that, is affecting policy, as it were.
Thank you, Zach, for your response. And Mutile raised her hand, and then also Julia asked a question in the chat box, but I'll ask her to ask in person, by herself. So maybe Mutile, go first. Thank you.
Thank you, Zach. My question is, I think maybe a bit more broad, thinking about how wealth inequality and some of these complex structural issues all play into the social determinants of health, which then now kind of contribute to vaccine inequity. What do you think about this? How do we actually kind of start to deal with the root causes? Because we know ultimately responding is good, but it's not enough.
Yeah, that's a very good point that you brought, and I think it does also introduce another dimension of the discussion. Though it's obviously not a new thought for anyone, I think, on this call, that there is a very direct correlation between how much disposable income countries have and the quality of healthcare services that they can provide to their citizens. And by inverse logic, it also means that the countries with very low disposable income also means that they are very limited in terms of what services they can provide to their citizens. So specifically what I think, or what maybe the general discourse has been around these differences in wealth and how pandemic should be responded to in these two contexts is one on the issue of collaboration. I know it's a toxic relationship, but it currently still remains one of the most effective approaches to trying to balance the equation when it comes to vaccine equity. Because as we sit right now, the LMIC region is not yet equipped to be able, number one, to produce vaccines at the speed that high-income countries would produce. Number two, the low and middle income region is not yet at the point where it can manage infections or cases at the capacity and with the quality that high-income countries are able to do. So because of this, it only leaves very few options on the table. One obviously is on data sharing. By data sharing, it actually doesn't just inform different regions, whether high income or low income, it also equips these regions in terms of what actually works in responding or managing these transmissions. For example, to go back to COVID again, I think a lot of the early thoughts around how COVID could be, COVID transmission could be prevented were mostly wrong, isn't it? Initially, there were so many discussions around, is COVID waterborne, is COVID airborne, is COVID, transmissible through aerosols, or is COVID transmissible through what? So when research has actually been done and there's been peer-reviewed, confirmed findings on how the transmission actually occurs, it's important through this, north to south or whatever direction collaboration that this data must be shared. By sharing this data, it also allows both the high income and low income countries to put in place, measures that would reduce the transmission. For example, lockdowns became a thing because we knew that super spreader events were, exponentially contributing to how many cases were being reported. Even though that study was not everywhere around the world, but the point is that that piece of information actually allowed countries to put in place, measures that, number one, prevented groupings or large groupings. Number two, also put restrictions on movement of people everywhere, willy-nilly, church gatherings, for example, or parties or whatever it is, funerals and all this. So these, when you look at these individually, you actually notice that these contributed to the management of the transmission rates. So if you look at the data from the pandemic, you can actually see patterns that follow some of these discoveries and the application of the interventions and how it affected the graphs in terms of caseload, death toll, and these kinds of things.
Thank you so much, Zach. And our webinar has come to an end. Does anyone still have a question? Yes, Yelena, please go ahead. Yeah.
I don't really have a question, but first of all, I just want to give my overview of this. First of all, thank you, Zach, for sharing everything today with us. I think this session only proved how complex of a problem vaccine equity is. Not only, I think, in low and middle income countries, but also across the world, because like coming from a pharmaceutical background, I just couldn't help but, while you spoke of this topic, just pinpoint all the different challenges that are not like even some problems that, like, you know, comes from the pharmaceutical industry, like how expensive the process is and everything, but also then the distribution and like equal distribution to everyone, which you spoke about. So I think even like that is one whole part, but then even when we reach the stage maybe to distributing the vaccines to all the regions that need it, and that is the whole world, for example, in the COVID pandemic, we then also reach, you know, I did some research on vaccine literacy and hesitancy that you mentioned. And, you know, it is that stage that we all, again, reach another problem, which is how much people trust the vaccines. Like, even when you provide them with a solution, you have a very large problem, you know, with all the theories that we, especially nowadays, like in the era of the social media and all the, you know, things and misinformation, disinformation. I think that's also like another very complex problem to combat. Like, we reach the point where people, even though they have a good solution for something, they do not trust it enough, or, you know, they've been misinformed. They do not know how to apply the knowledge, or maybe they do not even have the knowledge. So I think this session, like, even for me, who is very familiar with this topic, is so complex, and I cannot imagine like how complex this all will be to, you know, understand from a point of someone who does not come from this field. So I think this is why these webinars and, you know, having questions and, you know, direct speaking with the experts and the people who are very, very familiar with the topic are important. So I guess want to thank you for, you know, taking time to speak to us about this, because I think it is a very important topic. And I think that just by asking all of these questions from the present members, and then I'm sure that more of us will come up with questions just following this session, I think that it is important, and it just highlights how important it is that all of us continue working on this issue. So thank you really for taking almost 2 hours to speak to us. It was very informative, and I guess we all learned a lot from this session.
Thank you. Thank you very much.
Thank you. So I'm just going to read out Mutila's and Nicole's comments. Mutila said, interesting and complex conversation around data sharing, especially in the current landscape, where funding disruptions can actually lead to data loss, ref the pause on the DHS program. And Nicole said, I'm very surprised to hear that vaccine hesitancy and mistrust is an issue globally, as it is an issue here in the United States, where people have access but choose not to get vaccinated. Yeah. Thank you, everyone, for your questions. And thank you, Zach. Do you have any last words that you would like to share with us?
I feel like I've talked a lot, so I'm just going to say thank you very much, everyone, and Shirley and Elena for the invitation. And please, for those that may have some follow-up thoughts or are more interested to, you know, go down the rabbit hole on this vaccine equity thing, please feel free to reach out. Myself and our organization, we are, I think, very much in the weeds when it comes to this topic. So I'm happy to engage and discuss, and perhaps we can learn from each other. Otherwise, thank you very, very much for this.
Thank you so much, Zach, for joining us today and for sharing your knowledge. And thank you, everyone, for joining us today. And we will be posting this recording on our YouTube channel, and we'll be sharing the link with everyone, our LinkedIn. So yeah, I hope we stay in touch. And if you want to connect with Zach, I will help you to connect as well. So yeah, thank you very much, and enjoy the rest of your day. See you soon.
Thank you, everyone.
Bye.
Thank you. Bye. Thank you. Bye.